Classical QRS pattern in AST is the RSR prime in V1 suggestive of incomplete right bundle branch block. This pattern in AST is due to right ventricular volume overload. QRS axis is usually rightward, more so when there is severe pulmonary hypertension. Left axis deviation is usually a feature of ostium primum AST. First degree AV block may be noted in both primum and secondum AST. Familial AST with first degree AV block has been reported in secondum AST. This type of familial AST has an autosomal dominant inheritance pattern. There is also higher incidence of sudden cardiac death in this group. Cross-attach sign in AST manifests as notching of R wave near the apex in inferior leads marked by arrows. Sharp P waves in V1 and 3 mm tall P waves in lead 2 suggest right atrial overload. RSR prime S prime pattern in V1 is suggestive of right ventricular volume overload. ECG in AST with severe pulmonary hypertension. Tall R prime in V1, ST depression in inferior leads and V2 to V5 and T inversion in inferior leads and V1 to V6 are seen. Katz-Wachtel phenomenon sign is tall diphasic RS complexes at least 50 mm in height in leads V2, V3 or V4, that is a mid-precordial leads. The original description by Katz and Wachtel was published in 1937. The sign has been described in VSD with Y ventricular hypertrophy in children. It can be seen with isolated VSD as well as complex VSD. In fact, the article cited from Circulation was on complete transposition of the great vessels. An ECG with Katz-Wachtel phenomenon is shown here. The QRS amplitude is high and often overshoots the margin of the ECG graph as seen in lead V4 in this case. It may be necessary to take ECG in half standardization, that is 5 mm to a millivolt instead of 10 mm to a millivolt, to capture the full QRS complex without overlapping with other leads. Large anterior forces are due to the hypertrophied right ventricle and late posterior forces due to the hypertrophied left ventricle. In addition, this ECG shows negative QRS complexes in 1 and AVL, indicating right axis deviation, which is a feature of right ventricular hypertrophy. Right atrial overload is manifest as tall P waves in lead 2 and left ventricular hypertrophy with strain pattern is seen in lateral leads with tall R waves, ST segment depression and T wave inversion. The axis is leftward with predominantly negative QRS in leads 3 and AVF. The biphasic P wave in V1 with sharp atrial intrinsic cord deflection. The sharp downward deflection from the peak of the P wave to the trough of the P wave is a pseudo left atrial overload pattern seen in right atrial overload. In true left atrial overload, the atrial intrinsic cord deflection is more slanting so that the negative component of the P wave is almost U-shaped rather than the V shape in this case. All these features together in a cyanotic congenital heart disease is characteristic of tricuspid atresia. ECG in Epstein's anomaly of tricuspid valve showing right bundle branch block pattern with polyphasic and splintered QRS. The QRS is wide and lead V2 shows RS pattern mimicking right bundle branch block. Lead 2 shows multiple small deflections, that is splintered QRS. Slurred S wave in lateral leads also form part of the RBBB pattern. The duration of QRS has been linked to right ventricular enlargement and dysfunction in Epstein's anomaly. A larger atrialized right ventricular volume has been noted in these cases. As a corollary, those with near normal ECG would have mild morphological abnormalities and a better clinical profile. Splintered and polyphasic QRS of Epstein's anomaly can also be considered as fragmented QRS as per the new terminology. Fragmented QRS is a marker of myocardial scar and consequent arrhythmias in ischemic and non-ischemic cardiomyopathy. Similarly, fragmented QRS has been shown to be associated with larger region of atrialized right ventricle and increased risk of arrhythmic events in Epstein's anomaly. Epstein's anomaly may be associated with right-sided axillary pathway in ventricular pre-excitation, that is WPW syndrome, with or without atrioventricular reentrant tachycardia. Multiple axillary pathways can occur and radiofrequency catheter ablation is effective. Tall P waves due to gross right atrial enlargement in Epstein's anomaly has been called Himalayan P waves, though not seen in the ECG illustrated here. Himalayan P waves are also described in tricuspid atresia.